services for gender-based violence survivors during the COVID-19 crisis. My name is Alexina Rusere. I'm the GBV AoR Middle East and North Africa, and I'm with my colleague Pamela Marie Godet, GBV AoR Asia and the Pacific. The two of us will be facilitating today's webinar. Our colleagues, Jessica Gorham, GBV AoR East and Southern Africa, and Leigh Ashley, GBV AoR Asia and the Pacific, will be monitoring the chat, messages, and your questions for the speakers. Our dear colleagues, Sarah Martin from GBV AoR Community of Practice and Laura Martineau-Sell from the GBV AoR Help Desk will be monitoring the chat, messages, and sharing resources as applicable. In our first webinar, we discussed the impact of COVID-19 on women and girls and how to mitigate gender-based violence risks. And we had on board the researchers who conducted the systematic review to inform gender impacts of COVID-19. In the second webinar last week, we focused on how to undertake remote assessments to understand the evolving protection needs of women and girls and how to transition to remote service delivery. And our resource persons were from REACH, Informing More Effective Humanitarian Action, and International Rescue Committee.
Thank you, Alexina, for capturing the two webinars that we've conducted so far. I'm Pamela Marie Godoy, GBV AoR Asia and the Pacific. So we know that a great deal has happened in the past 2 weeks. The World Health Organization warns that while attention has shifted to epicenters in Western Europe and North America, COVID-19 epidemics are far from over in Asia and the Pacific. African countries move from COVID-19 readiness to response as many confirmed cases. Several countries have also imposed full or partial lockdowns and mobility restrictions. And we are also witnessing how the COVID-19 pandemic is straining health systems in many countries. So for this third webinar, we will be focusing on the health sector response to gender-based violence and how essential services can be continued when health systems are overwhelmed with COVID-19 crisis, and how life-saving services can be provided amid compulsory measures to prevent the spread of the virus like quarantines, curfews, and lockdowns. Similar to the first two webinars, we are all here for collective learning, problem solving, adaptation, and innovation, given this unprecedented and rapidly evolving situation. We are so pleased to have for our speakers this afternoon, Ms. Anna-Rita Ronzoni, World Health Organization Gender-Based Violence Advisor, Teresa Zakaria, World Health Emergency Advisor, and Emma Fitzpatrick from the Global Health Cluster, who will also be on the line to respond to any question relating to health cluster coordination and collaboration with GBV subcluster. So over to you, Anna-Rita.
Good morning, everyone. Can you hear me?
Yes, we can, Anna-Rita.
Yes, we can, Anna-Rita.
I think I will leave the floor for these first two slides to my colleague Teresa, as we are talking about the global update related to the pandemic. So Teresa, please, over to you for the presentation of the first two slides. Thank you.
Good morning, everyone, and thank you very much for this opportunity to share some of the information that we have, as well as the recommendations that we provide from WHO. So I'm sure all of you are very familiar already with the figures at the global level on the number of cases and deaths resulting from this pandemic. And so this is just a a map that really shows the extent of the spread of the virus. And as you can see, because the mode of transmission is really through respiratory products, then this is a type of disease that spreads very rapidly and very rapidly. And so you will see that there aren't many countries that remain white on the map. And you see that the evolution of the outbreak is also very dynamic. And what may be an epicenter now can be completely under control tomorrow. And locations where there are very little cases at the moment could actually then evolve into a full-blown community transmission scenario. And for our purpose, since we do work in the humanitarian sector, is actually these countries where we don't really see a lot of cases being reported yet, but the risk are omnipresent and the capacities to respond are extremely limited. And so actually, when we first drafted these slides, there were still, there were 3 countries with health cluster or sector coordination that had reported no case yet. But since then, Burundi has reported 2 cases, and that happened in the last days. And so therefore, there are only 2 countries with health sector coordination, health cluster coordination, where no case has been reported yet. And these are South Sudan and Yemen. Next, please. So who's most at risk? From the knowledge that we have currently on the disease, the elderly and those with chronic medical conditions are most at risk for poor outcomes and severe forms of the disease, all the way to death. And these medical conditions are diabetes, hypertension, and heart diseases. So what we don't have much information on yet are the diseases that are more prevalent in the developing world and in countries with humanitarian crisis, such as tuberculosis, malnutrition, HIV, or even malaria. So in theory, any disease that could weaken your immune system could result in the more severe progression of COVID-19. But so this is something that we need to watch out for and also to document properly so that the collective knowledge on the disease is also improved. So severe symptoms, however, can still affect people of all ages. It is true that fatality among children, especially the very young ones, is literally none. And that fatality increases with age, especially those who fall sick at the age of 60, 70 years and above. But we still see severe cases in people of all ages. Even in Europe, for example, in France, a couple of days ago, there was a report of a 16-year-old girl, no prior conditions, no comorbidity, who eventually died of the disease. So everybody should still watch out. So, and what's very important is that the consequences of this outbreak reaches way beyond the disease itself. I mean, it affects entire health systems. A lot of essential services are diverted to respond to the outbreak, and a lot of routine services may actually be severely impacted or be completely absent for a while because capacities are so limited and priorities at the moment to really prevent and contain the virus. The economic impact of the disease is also extremely big. So the UN actually yesterday released a report on the socioeconomic impact of the outbreak, which I would encourage all of you to also have a look when you have time. So I think this is, the next slide is another colleague who will be presenting, I believe. So next slide, and over to the next presenter, please.
Okay, thank you very much, Teresa, for this introduction, both on the current prevalence and also the risk most at risk group. Before starting, I really want to thank the GBV AoR for hosting us and allowed to use this great platform. I mean, there are many people online, so thank you very, very much for this opportunity. I will start briefly explaining the relation between the COVID-19 outbreak and the increased exposure to gender-based violence. Here we need GBV people. I know that you're already familiar with all of this, but however, today, as it's health focus, we have also many participants from the health sector. So I just want to make sure that we are all on the same page. So we know that gender inequalities are compounded by pandemic and epidemic, including risk of gender-based violence. And we know that even in time of non-emergency, GBV is highly prevalent. And based on WHO estimates, we know that 1 in 3 women have experienced a type of GBV in their lifetime. And we know also that the most prevalent form is intimate partner violence. Now, whether we have available data or not, we also know that GBV is likely to increase during every type of emergency, including epidemic and in this case, a pandemic, due to the stress, disruption of social and protective networks, and the decreases access to services. So we can definitely say that COVID-19 and GBV are interrelated pandemics. Why? Because specifically for COVID-19, the stay-at-home measures, so which include isolation and restricted movement to contain the spread of the infection, have a particularly acute impact on women who are living in situation of domestic violence and abuse. And we know that the health outcomes of violence can be very severe, whether physical, mental, sexual, and reproductive health related. So data are still scarce. As we know, there is a high likelihood to have increased exposure to GBV during every type of emergency. However, during this month time, we had some reports from different countries. I mentioned China, UK, US, and other countries, who suggests that there is an increased number of domestic violence cases reported. In China, for example, it has been noted 30% more than the previous year of cases reported. Same in France. And yesterday I read from a Lebanese newspaper that women organizations in Lebanon are reporting actually increase of 60%. So, however, we do not need data. Data are already there and are demonstrating this very strict relation between GBV and COVID-19. Next slide, please. So now, if we look at the pathways of risk, as we mentioned, in the case of COVID-19 pandemic, the measures put in place by government to mitigate the spread of infection focus on stay home. And we know that unfortunately for women who are living with a situation of violence, home it's not actually a safe place to be. That means that they are obliged to spend more time in close contact with their perpetrators inside the family. And from the other side, they have less opportunity to receive support from other family members or friends. And we know that in this situation, violent behaviors of perpetrator may be further exacerbated by the stressors that we all know, like loss of jobs or other stressors. Also, we are noticing that perpetrators are using restriction due to COVID-19 to exercise power and control over their partners. And I'm Italian, and my colleagues in Italy working with in women organization and providing anti-violence services are actually reporting a drop of around 40% of call of survivors to anti-violence centers. That means that perpetrators are controlling survivors, and there is a difficulty in actually asking for help and seeking for support. They cannot call hotlines. From a health perspective, of course, these measures reduce the access to health and to other services from one side, but also, as Teresa was mentioning, because of the response, the focus on the response to COVID-19, the access to sexual and reproductive health services and other services for women and women survivors of violence will be most probably limited, because resources, health resources and medical supplies are diverted to respond to the pandemic. So survivors are left with less chances to seek for help and find actually help. Also, if we look from the other services perspective, like hotline, crisis center, and all the other protection services, again, we can have a scaling back of those services. So it is very important, and I hope that during this webinar, all participants will be able to brainstorm and inform us about new ways to provide services, if they are already activated, new way to provide services. So from a wider gender perspective, of course, there is the brunt of increased care and domestic work for women and reduced economic independence. Also, we have to look at women, especially in humanitarian contexts, who are displaced, living in conflict-affected areas, and also women with disability as even more vulnerable. Last reference to children, because it is true, women are living at home with their perpetrators and may be subjected to increased violence, and their children as well may be witnessing violence perpetrated against their mother from one side and be directly affected by the violence. And also, and finally, as in other emergency, there are negative coping mechanisms family may put in place, such as, for example, child marriage. We know very well from our crisis in the Middle East how much the child marriage increased during crisis. Next slide. So within WHO, we have been brainstorming very much. We produce a guidance on how the health sector response may be shaped during this COVID-19 crisis. It is very difficult in this moment of health emergency to talk about the health sector role, but we still think that health services can support survivors. How? It definitely by ensuring continuity of life-saving services and strengthening referral linkages with other services. Also, even in this time of pandemic, GBV survivors will see health facilities maybe as a safe space. So it's very important health providers are prepared to provide first support and refer if needed. Now, the aim of this webinar, as well as the WHO release guidance for us from a WHO and health sector perspective, is to increase awareness of the health sector and the health provider about the persistence and the increase of GBV during this pandemic, and to strengthen the internal response from one side and the multi-sectoral coordination from the other side. So if we look at, from a health facility perspective, again, repeating myself, referral pathways are so important. They should be updated and include all available services so that the referral as much as possible can be quick and safe. Health providers, we think that still health providers should be trained about the risk for increased violence against women during this time, so that survivors, if they reach facilities, can still receive appropriate care. And even patients presenting with no specific complaint, whether headache, abdominal pain, so forth and so on, health providers should keep in mind that they could be GBV survivors. Of course, All of this following the regular COVID-19 protocol to reduce the risk of infection, because even if a woman comes to a health facility complaining for GBV health-related issue, she may be COVID-19 positive. So it is also important to follow all the regular protocols. Teresa also was mentioning that in many countries still we are in the preparedness and we are stepping into the readiness phase. So we think it's very important to include the GBV into the COVID-19 response plan. So mapping, health facilities readiness assessment may include one question or two related to the GBV services and data collection. And finally, the community. Community is very important in this time of closure, of isolation, of impossibility to reach out services. So whenever we reach out to communities, we need to stress the importance of the risk of increased domestic violence and how communities can support survivors to ensure they are protected and safe. I think I will stop here. And I think next slide is for Teresa. Over to you, Teresa.
Thank you, Ana Rita. So now just a quick refresher on how this virus is actually transmitted from person to person. So it's a respiratory disease, meaning that the virus is contained in respiratory products. So when we talk, when we sneeze, when we cough especially, a lot of virus particles then spread into the environment. Now, luckily, the virus particles need to be attached to respiratory products such as mucus and saliva. And this is then how it reaches the environment around the infected person. There are two main routes of transmission for this virus, which is through direct contact by basically being exposed to the droplets, the respiratory droplets directly from an infected person because we're standing way too close to this person, or these droplets can fall on hard surfaces around the infected person, and these droplets are then touched by other people who may not be present at the same time, but because the virus can still live for some considerable time in open air, a person then touches droplets left on surfaces, and then this person would then go on touching his or her face, especially the nose, the mouth, and also the eyes, and that is then how the transmission also occurs. So what I would like to also now bring your attention to is to the third star. So droplet transmission is like taking a spray bottle, right? And some of the droplets may land on and be breathed in by others, and some may land on surfaces and serve as a source of transmission. Maybe I would also like to take this opportunity to refresh everybody on WHO's position as well when it comes to aerosol. At the moment, there is no clear evidence that the virus is actually transmitted through aerosol. When I say aerosol, these are the smaller particles that are produced by people talking, sneezing, coughing, but that reaches further distances than the droplets because they're lighter, and they may evaporate and leave the virus then floating in the air freely. So there is no evidence that there is enough aerosol generated that contains the virus to actually be able to infect other people, with the exception of healthcare providers who are performing aerosol generating activities, such as, for example, intubation or cardiopulmonary resuscitation that would force the body then to produce much more aerosol than in normal settings. Next slide, please. So then how does this affect our GBV services? First, a point to remember that is extremely important is that GBV services are essential. And even in WHO's guidance on maintaining health services during the outbreak, GBV services are classified as one of the essential category of services that really needs to be kept regardless of the status of transmission, regardless of the evolution of the outbreak in a specific setting. And therefore, we need to also be able to position this very carefully in any operations related to COVID preparedness and response. Now, for every individual setting, a risk assessment that is specific to that setting needs to be carried out to properly evaluate the risk of exposure to COVID-19 and how to better secure then the service provision. For example, in some areas where a lot of transmission is happening, the health authorities might want to dedicate a building or a separate health facility as the place to provide COVID-specific interventions, and then leave other health centers to give all the other services that are not COVID-19 related. Now, this is a good example. Now, what is extremely important, however, is that a triage is properly done, so that in health facilities that are allowed to continue and are encouraged to continue essential service provision, there is a good triage at the entrance of the facility so that anybody who may potentially be a case of COVID-19 is therefore then immediately referred to the other dedicated facilities for COVID-19 to protect everybody else, patients, doctors, staff in the first health facilities where essential services are being provided. So, and then the mode of delivery of these services would also then need to be taken into account. Do we want to keep face-to-face consultation? Do we want to perhaps transition some of the activities into outreach, such as antenatal care, for example? Or do we want to rely more on technology and enable telemedicine, for example? So there are a lot of ways to transition service prevention, a lot of different modalities, but then the risk and the benefits of each of them would need to be carefully evaluated, and these needs to be done per setting. So there cannot be a global guidance that exactly tells you how to do this at the community level, at the local setting. And then subsequently, service providers should then develop a plan for the workplace, how to best secure the workplace to make the workplace and therefore then the clinic or the women's safe space, for example, to be safe for the survivors, for the clients, as well as for the service providers and support staff as well. So please remember that there is no one-size-fits-all approach, and we will very much depend on the health, public health expertise of all of our partners to be able to digest, interpret guidance that are published by WHO, and then to adapt it to the local context. Next slide, please. So then, what adaptation should be made to reduce the risk of infection? So first of all, if you are planning to keep a location, physical location, where services will continue to be provided, then there has to be a system for triage, so that those who may show signs and symptoms suggesting COVID-19, who may be at risk of being exposed to COVID-19, could be detected as early as possible and be then treated according to the alert management protocol. So obviously there has to be strong linkages with the rapid response teams and the COVID surveillance team in charge of your area. Now, there are very basic rules that unfortunately we cannot really compromise on, and these are all related to the modes of transmission that I've mentioned earlier. So first of all is to ensure that there is safe distance among the women and the girls, or maybe the boys who would be accessing the services. Safe distance between then the patients or the survivors with the service providers. And this needs to be kept all the way throughout the entire duration of presence of every single individual in the facility. So we can be very creative on how to keep the safe distances. For example, by reaching one-way flow that are demarcated by tapes, and that would then ensure that there is no contact among individuals. There needs also to be a strong monitoring and supervision system in place to make sure that when bad practices are observed, that they are immediately addressed. The second one is hand hygiene. Again, back to the mode of transmission. When we touch hard surfaces that we don't really know whether somebody has coughed on or not the 1 hour before, it is therefore extremely important that our hands are clean all the times. And so in these facilities where we provide our services, we need to make sure that there's sufficient hand hygiene materials and equipment, and also covered waste bins. Because if you choose, for example, to dry your hands with single-use tissue paper, then you would want to then throw it away immediately in a covered bins. So then these hand washing facilities could be set up at the entrance, even before lunch, in the waiting room, and then also, of course, in the consultation room. And then respiratory hygiene, this is also a very important rule. If somebody has respiratory symptoms and they're not suspected of COVID-19, because if they were, they would already have been picked up during the triage, then these people who continue into registration into the waiting area should wear a mask. It is extremely important that those who are sick wear a mask. And others should be informed of respiratory hygiene. So cough, sneeze into your elbow or a disposable tissue, but then this tissue would need to be discarded immediately. And then healthcare providers, according to their own evaluation of their risk of being exposed, should then use personal protective equipment according to the risk identified, be it a mask, and normally masks would need to be accompanied by goggles. And then also then, if, for example, a person is prone to be in contact with a lot of body fluids and respiratory fluids as well from patients, then he or she would also then need to think about wearing an apron, for example, impermeable apron, and make sure that the clothes are actually clean. So it is recommended that service providers also then change clothes into a work clothes, a scrub, when they provide consultations, which are then washed properly before leaving the facility, and therefore then the clothes that were worn when the service provider left the house is the same that they are going to use when returning to home, and completely different than the set of clothes that they're wearing during consultations, during service provision. Next is the importance of cleaning the workplace. Again, all surfaces, especially the hard surface that are frequently touched, need to be properly cleaned with household detergent. Is fine, but this needs to be done more rigorously, and ensure that there's a safe waste management according to the local regulations. If there are equipments that are used by multiple patients, survivors at the same time, then we need to make sure that the transition of patients also includes proper disinfection of these equipments. Now, the advantage of continuing service prevention is also this opportunity that is created to communicate risk. So then while women and survivors are present and wait for their turn for consultation, then it is good to always remind them of the risk of COVID-19, how to recognize early the signs and symptoms, make sure that there are written materials and pictograms on the walls of the facility. And it may also be a good opportunity for the service providers and the team to also then collect feedback from the women and the survivors on how they think these measures are understood, are feasible to implement, and also then to address concerns. Okay, so I will hand over once again to Anrita for the following slides. Over.
All right, thank you very much, Teresa, for this, for reminding us about the ways or the measure we should adopt to reduce the risk of infection. I think this is very important. We have to bear always in mind these points you mentioned. Now, we are talking a lot about the need to reinforce linkages between health and GBV sector, and we know that by nature the response to GBV is multi-level, multi-sectoral response, specifically in emergency and specifically in this COVID-19 pandemic. On your right side of this, on the right side of the slide, you will see the cover of the Global Humanitarian Response Plan COVID-19, where I mean, there is it's clear the importance of keeping in mind consideration related to both gender and GBV. Specifically, GBV is highlighted in the strategic priority 2, which aims at ensuring continuity and safety from risk of infection of essential services, including health, and between brackets also gender-based violence is mentioned, along with other important points for the population groups most exposed and vulnerable to the pandemic. This is the strategic priority 2. Now, we are aware that given the demands on the health system, the joint action from multiple services provider is the only way we can ensure GBV survivors continue to receive support. Also, given the demand and the pressure on the health system. At the same time, as WHO, we count to expand the discussion around the role of the health system and also the role of the health cluster, and we hope to be able to leverage the contribution of the health cluster, for example, including monitoring indicators or including GBV in the health facility readiness assessment, and our WHO country teams. Of course, in this very moment of the response, they are all focused, obviously, on the response in terms of slowing the transmission and respond to COVID-19 cases, which is within the strategic priority 1. But we hope that we will also able to enhance their participation and through the coordination with other agencies for the strategic priority 2. Next slide. So the last slide is basically, my last slide is basically about what are the immediate priorities for joint action. We know that we are in a learning process. This pandemic is new for everyone, so we are not prepared and we are learning as we go. But there are definitely some action that we should prioritize. In the health system, definitely prioritizing essential GBV life-saving services. We have to make sure they are maintained for survivors. We are talking about domestic violence, violence at home specifically because of the specific nature of this pandemic, but also we have to keep in mind the importance to keep running safe services such as the clinical management of rape, because as we know from other health emergencies, there is also there will be definitely exposure to sexual violence, sexual exploitation and abuse. And so we need to keep in place life-saving intervention along with minimum first-line support when possible. In the next slide, you will see that we have put there resources. No, sorry, it was just mentioning the next slide. If you can go back to the previous one, sorry. And one of them is the just released risk clinical management of rape guideline, where it is the new updated guidelines take into consideration not only the actual clinical management of rape, but also in these updated guidelines, a lot of focus is put on intimate partner violence. And it's very timely that this guidelines is released now, where this emergency focuses not only on the response to sexual violence, but very much to the response to IPV, as well as mental health and psychosocial support. Second point, very important, is to ensure that referral pathways are updated. Many services may be closed, maybe switch to another modality. So we need to have a mapping and a constant update of all available services, especially having phone numbers that are working and as well as email that are responding. They need to recognize we need to recognize the need to adapt and innovate our usual program approach. Again, we need to think out of the box we need to rethink approaches, both for GBV and health services. As I said, we are in a learning process while we live this emergency. So I really hope that you will share, people working in the field, the challenges that you are facing right now, and also if you have in place good practices that you can share, because your contribution is really fundamental. We can set up guidance, but you are really the one who give us the feedback about the feasibility of those guidelines and innovative approaches. Uh, of course, sharing technical guidance and resources in a coordinated manner. And finally, the need to mobilize trainings and resources as needed through vertical trainings on GBV and through trainings for health providers on, for example, COVID response that have also GBV integrated in the training package. So the last slide, I will just leave you like 30 seconds to read the but then it is recorded, so you can go back to those resources. Basically, we have the first three resources are focusing on GBV, the guideline published by WHO on GBV and COVID, the updated clinical management of rape, and then the strengthening the health system response for women subjected to IPV or sexual violence. And then we have two WHO resources specifically focusing on COVID. I don't know if, Teresa, you want to say one word or two on this? Yeah,
Thank you
so much.
And Teresa for the valuable inputs. It's very important that you have highlighted how COVID-19 and gender-based violence are interrelated pandemics, and the need to adopt approaches based on risk assessments, country context, as well as the latest COVID-19 guidance, and the need to have the multi-level, multi-sectoral support to GBV survivors. Before we go through the question and answer portion, we'll just visit some slides to highlight the challenges that our GBV coordinators are facing in the field in relation to continuity of essential services for GBV survivors, and some examples on how they can be addressed. For service providers and staff, we have to consider, for instance, do they have adequate supply of personal protective equipment? Given the high demand and low supply, there are 3D printing companies in various countries like Czech Republic, Sweden, and the Philippines who have created an open source design for a face shield to be worn by healthcare workers. And there's an ongoing community-driven effort to mobilize those with 3D printers to help produce printed and laser-cut face shields. So this is just an example. We also have to consider if service providers can reach their places of work given the mobility restrictions and lockdown measures. We've heard tragic tales of discrimination against health workers and frontliners. There are testimonies of doctors and nurses being kicked out of their rented apartments due to potential contamination fears of their neighbors. So in Portugal, some property owners are offering free accommodation to health workers. In Indonesia, Jakarta's COVID-19 task force said that the city is providing medical workers with sleeping quarters so they could get some rest without having to travel all the way home after long hours in the hospital. In the Philippines, as all forms of mass transportation were stopped due to the quarantine for the entire island of Luzon with more than 50 million people, frontline workers are, of course, finding it hard to reach their places of work. So the government, specifically the Office of the Vice President, in partnership with the private sector, NGOs, and even Rotary clubs, have rolled out free shuttle services and free dormitories for health workers. Also in the Philippines, bikers lead initiatives to lend bikes for doctors and nurses. They even created a Facebook page to be able to match bike lenders with doctors, nurses, and other frontline workers who now need to bike to work. In terms of considerations for GBV survivors, we also have to check if they can reach health facilities in the first place, given restrictions of movement, physical distancing measures, and lockdown. Can transportation be support, can it be provided? Is it feasible, for instance, to refer to a mobile service delivery provider? Or can a trained doctor on clinical management of rape be part of the COVID-19 outreach team? For scenario B, shifting to remote case management, there are existing guidance notes from the GBV AoR Help Desk and GBV IMS Steering Committee. The shift will, of course, include updating of GBV referral pathways. It needs to include setting up or identifying existing hotlines in preparation for the disruption of static service provision. In preparation for the shift, for instance, the facility can procure mobile phones, prepaid internet cards, and even charging devices for areas with very poor or unreliable electricity supply. There is a need, of course, to put in place staff care support that can be implemented remotely. And speaking of the well-being of staff, the GBV AoR has released yesterday the mental health and psychosocial support considerations for staff working on GBV prevention, mitigation, and response during the COVID-19 crisis. We know that emergencies are always stressful, but specific stressors include such as the risk of being stigmatized due to presumed exposure to infected people, even the increased vulnerability of female staff to intimate partner violence and other forms of domestic violence due to isolation and heightened tensions in the household, and even the frustration given the inability to sometimes provide the usual set of life-saving care and support to survivors due to stay-at-home lockdown measures. So we hope that this initial briefing note will be helpful for you. This is a slide also in terms of examples from the field. We know that different country contexts are in the process of revising their referral pathways to reflect both static and mobile service delivery. With the imposition of a national lockdown in India, the police has launched a special hotline for victims of domestic abuse. Supposedly, upon receiving complaints, a women police officer will personally visit the complainant and the victim and ensure her safety, and at the same time will make arrests as necessary. An interagency mechanism on anti-violence against women and children also announced hotline numbers for survivors, and this is in the Philippines. Professional associations of social workers and social workers in provincial and city governments have also started offering free confidential telephone and online psychosocial support and psychological first aid. And this is also an example coming from the Philippines. And we've also heard of initiatives to create safe quarantine spaces for women, such as in Pakistan. So as GBV coordinators and specialists, it is crucial that we collaborate with the hotline providers to ensure that they communicate consistent life-saving GBV messages and they have the latest GBV referral pathway. And since we have the global health cluster on the line, these are some possible linkages and points for collaboration between the health cluster and GBV subcluster in terms of GBV integration into capacity buildings of COVID-19, health cluster-led assessments wherein GBV can be integrated as well, and the integration of indicators in health cluster COVID-19 response plans. So that's it for now, and we turn you over to Jessica and Lee Ashley for the question and answer portion.
Thank you, Pam. It was great to be able to see everyone's questions in the chat. And I've noted down a few, and I think Leah Ashley, you have as well. But maybe I will start with the health cluster, and then Leah Ashley, you can go back to WHO. But specifically for our colleagues at the health cluster, 2 questions have come up. One is, are you aware of what the role of the health cluster will be at country level in terms of coordination? We've been getting some feedback that the health cluster will lead the response at country level. And then at other times, we're also getting feedback that OCHA will then lead the response. So if you have any insights on that. And then the second one is about training healthcare providers. Is there any guidance from the health cluster? We know that usually during emergencies, we don't do any training at the onset of an emergency, but we're still seeing sometimes revisions of work plans that include the training of. So if there is a position cluster on the training of healthcare workers, that would also be useful. Thank you.
Hi, yes, this is Emma. Very quickly, the response for the COVID at the country level, it's very much a HCT-led response. Now, WHO and the health cluster supporting WHO as well will take a strong role in the technical aspects of that, and they'll obviously be very prominent in many of the discussions. But it is very much quite clear from the very beginning is that generally it's up to the HCT to decide the appropriate mechanisms for the coordination. What was very clear at all levels, the EDGs and other discussions we've had, is that the aim is not to create new systems. So the systems of the HCT overseeing the coordination of any response to all humanitarian needs will stay in place, but obviously different partners and different agencies will take a stronger role in some aspects of that. So the idea is very much, it's not at country level, it's not a WHO response, it's a HCT response, and the coordination mechanisms should not change. But obviously if they choose to do so, that is up to each country to do. But what we're hearing is generally much still the HCT leading that. In areas of, I guess sometimes it can go, I have heard that some countries are looking much more to WHO to lead some aspects of it. I think the second question about new work plans, with the introduction of the humanitarian response plan, the idea of that plan is to support and help guide what any amendments or slight changes that they need to do to the humanitarian response plans. What most countries are doing are also they're revising the HRPs just to try and add to or add on to the HRPs as well as the COVID-19 response needs. Again, in theory, the idea is that this is not to create a new plan, but to make sure that the new needs coming up from COVID-19 are reflected in the humanitarian response plan, but really important that the current needs and basically the current needs, but also the humanitarian needs are not forgotten. So some things might need to be reprioritised, but ideally they won't fall totally away. But I think reality might be that some things might need to be, I think it's more reprioritised than forgotten as such. I hope that was clear. Teresa, is there something you'd like to add?
No, nothing for now. Thank you.
Okay, thank you. I think we're going to move on to questions for some of our WHO colleagues that presented. We had quite a few, so I'm going to just narrow down some of them. We had one question about using pharmacists as screening access points for GBV survivors. A few of our participants had mentioned some best practice that is happening in Spain. And so others have asked if you know of any guidance around this, or if it's happening more large scale. That would be the first question. And we also have a second question about whether you would see the guidance that you have provided would be relevant to one-stop centers, which are centers that provide comprehensive services to survivors of GBV, or is there a separate set of guidance that you would recommend for one-stop centers specifically? And I'll turn that over to Teresa and Anna.
For the for the question related using pharmacies, so this is something that was initiated in Europe, in Spain, and then also now it's been implemented or adopted, let's say, in Italy and in France, as far as I know. So basically, when there is a code, which is mask 19, when survivors go to a pharmacy and say this code mask 19, the pharmacist should be able to understand that they are in trouble and refer them to put them in contact with services. This is an initiative that was, I think, based on the initiative of women's organization. And as far as I know, is being implemented now in these 3 countries that I mentioned. Yesterday, we were talking about this, and also we were discussing, okay, but now this code that should be kind of a secret, it's now known by everyone. So we are wondering also in relation to confidentiality, how much this is going to be effective. I mean, this is absolutely a very important initiative and one of the alternative ways to try to respond to survivors' needs. So it is very just started, so we really don't know how it is working so far. And as far as I know, as I said, in those 3 countries, the guidance that we released, well, they are basically is a guidance for health providers. I mean, for different levels, for governments, for health facilities, health providers, communities, and also women themselves. Again, how much this can be adapted to one-stop center, if we have health services there, definitely they can be adapted. For the one-stop center, I don't know. I think it depends from case by case, from country by country, which kind of measures are put in place. Like you know, curfew are in place. Are those one-stop centers still accessible, or they switch to remote support? So I mean, I think that it really depends from country to country, case by case, but definitely the guidance can be adapted to different for different type of settings. And again, they really stress the importance for health providers to keep in mind that GBV during this pandemic emergency is there, is prevalent, is increasing. So how we can, if we can, as health providers, provide life-saving intervention, provide basic first-line support, and refer to other services. I hope I answered to the questions.
Thank you so much.
So this is Teresa speaking. If I could also mention, I don't know whether it's possible to go back to slide number 7. But so the considerations, the recommendations for triage, safe distance, hand and respiratory hygiene, environmental cleaning, and risk communications, these are cross-sectoral recommendations. And it really needs to be implemented in all settings, in all types of service provision, regardless of the context. It should even be implemented when we do outreach activities and visit homes. So we also are at the moment in the middle of developing another guidance document, laying out specifically these priority recommendations to ensure safety, basically, to ensure that we reduce the risk to the maximum extent possible for the introduction and spread of COVID-19 in any type of humanitarian operation. So then these are really principal recommendations that should be implemented at all times. can be in a one-stop center, it can be during a house visit, it can be in a large hospital. So I think that there are these key principles that should always be followed. Over.
Thank you so much, Teresa. I have a few more questions from the chat box. We had one question about assessment. So perhaps this could go both to Emma and Ana Rita. How can GBV actors work with the health actors, health cluster, and direct service providers in order to do assessments, both of facilities as well as assessments of the capacity needs in order to respond to GBV?
Emma, do you want to go first?
Real quickly, actually, can I question, is Nim still on the phone? Because she's our information management specialist for the GBV. She's there. I might pass it off to her quickly, but she said you might need to leave. Nim, are you there? Okay, no, sorry. So in general, what's really important is at the country level that all focal points engage really closely with the health cluster coordinators. The assessments, as you know, a lot of those happening through them. The best way is that they connect. I think even though WHO will be doing a lot of those assessments, there's also, they need to look at what currently is available, the information that's there at each level, at the country level, but also engage really strongly in the ICC group, because often, as we all know, it is OCHA. Often OCHA will start ad hoc multi-sector assessments as they go forward. The best thing really is to contact the coordinators. If anyone has any difficulties with that, please do not hesitate to get back to us, and we can help make those linkages if something goes wrong there on that level. And I'll try Nim, who was just on the phone on the line earlier, about indicators and things like that. I'll get her to share some information with her because I know she's working on that specifically. Sorry if that's a bit
may I
vague.
add?
Yes.
May I add something? So in relation to the assessments and what we said about, of course, we are in the middle of a very severe crisis and emergency, and what we could do from a health perspective is definitely to ensure that the life-saving services are there and minimum standards are still there when we receive GBV survivors. So in the assessment, it could be assessed from a health facility perspective if there is a space to run confidential meeting with the survivors to assess their exposure to GBV in a confidential way. We could assess if there is in place the kit for the clinical management of rape, and also in terms of training, as we say, if health providers are trained to receive GBV survivor and then treat them or refer them.
Yeah, I think a lot of things, I mean, COVID is, I mean, obviously one aspect of a response, of the response, but the the Public Health Information Services and the standards and the tools that are related to that are being rolled out in all of our countries to varying degrees, but through our HERAMs, which is, and other assessments that are ongoing. So the very first thing to do is to look at the information, look at what is currently being undertaken and how that information can be possibly better used and feed into the overall analysis. And then if there are gaps, then work with the health cluster, and or if needed, if there isn't, most countries they do have an assessment working group to try and bring in the most critical aspects if further assessments are going forward.
Thank you. That's excellent. We have one more question, and this is related to the remote management of the health aspects of COVID. Several people have asked questions about how can GBV be integrated when health workers are doing remote contact with patients. I don't know if you have any best or emerging practices in that area that you're able to share, but it links to the previous questions in terms of how do we need to link with each other in order to build the capacity of health workers who may receive disclosures? Thank you.
Well, this is an ongoing conversation, really. Again, this emergency is so new to us, and we are brainstorming all together how to provide even alternative support to GBV survivor from health providers. So one of the options that we are investigating, thinking about, is training doctors who are working in telemedicine and are working remotely on providing basic first line support. I mean, when we train doctors, usually we tell to them that the most important thing they can provide to survivors is initial first line support. So one of the options could be train those doctors. We receive calls from survivors how to provide very quick first line support.
Thank you. That's very helpful.
Still under discussion, under brainstorming. We don't have any practice so far initiated in this sense.
Yes, and thank you. I really enjoyed the way you called out to the group that we're all working together in this and innovating. So I think that we all will be moving forward and sharing our practices through the community of practice for GBV. As well as the GBV AoR website. So thank you so much. Maybe I'll turn it back over to you, Pamela.
Okay, do we have additional questions, Lee Ashley and Jessica?
I think we've answered all of the health-related questions. There are some questions in the chat on other topics that we've noted. So for example, how to manage hotline referrals, how to improve safe shelter services for GBV survivors, and preparedness and response activities targeting adolescents for GBV. I think those are probably beyond the scope of this webinar today, but we have noted those questions down so we can work to provide resources through the GBV AoR and community of practice forums. And we can continue to share that guidance in the future.
Okay, so thank you everyone for your precious time and for your active participation. We do have a post-webinar survey this afternoon. So Lee Ashley and Jessica will be posting the link. So it's bit.ly GBV AoR webinar survey. So it's just a few questions just to enable us to capture what you're learning so far and the areas of topics that you want to focus on the upcoming webinars, since we will be having this until the end of April. So Lee Ashley and Jessica, is the link already on the chat window?
Yes. Yes.
All right, great. So this is our last slide for this afternoon. So as you know, as in the last two webinars, we have a French version that will be facilitated by Noemi and Luana. And then next week's webinar on April 9 will be focusing on ensuring an efficient integration of gender-based violence in emergency in the COVID-19 humanitarian architecture response. And the time would be 10:30 CET and 11:30 EAT time for the English version. For the other technical support on GBV in emergencies, please contact GBViE Help Desk. They have released 2 critical documents already relating to the COVID-19 pandemic. One is on GBV case management, and the other one is disability considerations in GBV programming during the COVID-19 crisis. Please keep checking the GBV AoR website for news and events, as well as updating of the COVID-19 resource page. And please, if you're not yet a member of the community of practice, please join. I'm sure Sarah Martin has indicated how you can join in the chat window. And we hope that you continue sharing with us any emerging best practices or lessons learned that you are coming along at your various country contexts. So thank you again, everyone, and see you next week.
So
Bye.
I just want to insert that yes, we've noted that there is an issue with the link to the survey. So we'll also find a way to post it through the GBV AoR and COP if you're not able to access it today.
Okay, thank you, Lee Ashley, for that. So thank you, everyone, and stay safe and healthy, and see you next week.
Thank you.
Bye-bye. Thank you.
Thank you.
Bye-bye. Thanks.